Welcome, everybody, to the latest in the ICRS journals. I'm going to share my screen. If you just give me a moment, we will switch our screen share. Okay, hopefully everyone can see that. Welcome to Adventures in Joint Preservation. We're going to discuss some complex cases today with some true experts, discuss how to deal with getting the best and lasting results. Your hosts today are myself, Ken Zaslav from Lenox Hill Hospital in New York and Northwell, and Tom Minas from the Paleo Orthopedic Institute in West Palm Beach, Florida, formerly Harvard University. And our discussants are the illustrious commentators Dave Flanigan from Ohio State University, Deryk Jones from Ochsner Institute, and Seth Furman from Stanford University. Tom, why don't you take it away with the first case?
Sure. So welcome, everybody. Another one of our virtual sessions, which have been very useful and interactive. And we're going to try to give you guys a flavor of just what the experts would do today. And I want to thank our three illustrious experts that they're here. So the first case is this young woman who presented to me. She's 19 years old, a former dancer, very fit and healthy, 19 years old. And she started to dislocate both her patellas at the age of 13. The left is more problematic than the right. Her goal really is to stop dislocating recurrently and resume dancing. She has a lot of other soft tissue laxities, elbows, hands, etc. The question of Ehlers-Danlos syndrome came up with her. Of course, we can't demonstrate that by any genetic testing. She had a prior MPFL reconstruction with allograft tendon, and that didn't seem to help. It helped initially, but then it continued. Next slide. I think you have it, Ken. Sorry, I got it. Yeah, so here's the these are the standard x-rays that we'll see all day today. We'll present all our cases this way. So we have our long alignment x-rays, and you can see she is about 2 degrees overcorrected into valgus on both knees. You can see also her standing AP and PA. She's got well-preserved joint spaces. Next slide. And her knees inflection, her merchant views, they reduce quite well. But you can see both, she's got a little bit of patella alta, and it appears to have a crossing sign in the proximal part of her trochlea on both sides. So it looks like she may have some dysplasia. Next slide. And this is after her MPFL reconstruction, and you can see a typical J sign. She is dislocated in extension and relocates in flexion. And here we have an example of her tibial tubercle, tibial groove, or TT-TG distance. Looks like it's about 18 millimeters. So that's where we stand. I'm open to answer any questions. She had arthroscopy performed, and you can see her focal grade 3 and 4 area of damage with her patella subluxed at least 50% in extension arthroscopically. The trochlea was intact and healthy other than the dysplasia, relatively flat. And her defect, grade 4 defect, was 20 millimeters by 15 millimeters measured arthroscopically. So let's go to our discussers.
So today we'll start with David. Why don't you start this one, David?
Sure. So Dr. Minas, tell me, was it primarily instability or pain or both?
Both. Yeah, she would dislocate unexpectedly, have falling and giving way. But even when she was just climbing stairs and sitting, she had anterior knee pain. So she had both instability and pain.
Yeah, I think, this is a great case because it's obviously something we commonly can see, especially with patellofemoral instability. unfortunately, she's already failed one procedure. So then whenever you think of a failure procedure, you have to think about what are the causes, what are the other issues that may not have been addressed, so that we can now hopefully give her success, right? So especially in this, I look at number one, she has patella alta. Do you know at what point in her knee flexion that some of her instability resolved? Was it at like 60 degrees, or how far down was she unstable with her apprehension?
Yeah, I didn't really assess it that way. You know, I'll go through that when
Sure.
we do our open surgery, but really it was just clearly that in extension and early flexion, she was unstable. And then
Right.
as she relocated, as you could see during her J sign, that was stable. I'm guessing it was probably around 30 to 45 degrees she relocated.
Okay. Yeah, so I see that she has a significant J sign, obviously trochlear dysplasia, patella alta, cartilage defect with a failed previous MPFL. So, for this, in my hands, what I'm thinking at this point is to address this with a bony procedure as well. And I would often do this with a distalization. And then if I'm dealing with the cartilage at the same time, then often I will do some anterior medialization as well to offload the cartilage. I often will still revise the MPFL. I think especially with some of the Ehlers-Danlos, or if they have loose tissues, I think having that check rein is going to be important. I think just her bony anatomy allowed that ligament to finally fail over time. And then also with that significant J sign, if I would, test some of those lateral structures, were those pretty tight on your standpoint, Dr. Minas? And I saw your X-rays, and those overall look good as far as it being pretty central. But if she had tight lateral structures, and I would also consider a lateral lengthening at the same time.
Yeah, she was loosey-goosey in both directions. She would slide medially and slide laterally, but her dislocations were all lateral.
Okay, guys, we have 7 minutes left on this. Deryk or Seth, you want to add anything or disagree?
I agree with Dave. I think for this one, you have to decide and always try to treat the joint as an organ. So I try to tease out pain versus instability or both. If she's having painful chondrosis, effusions between episodes with a cartilage defect that's weight bearing and relevant, then I think you do have to treat all, which to me may move me for the patellofemoral joint to a 2-stage solution. So first stage might be the scope, understand size, depth, location of the cartilage defect, look at tracking, even using a 70 degree from above, look at the trochlea and, make a plan and then come back and execute, which is what I would do. So I would do unloading TTO, MACI, revision MPFL with allograft because of the Ehlers-Danlos issues. But I do that preferentially and likely lateral lengthening. I agree with anteriorization as part of the strategy, not over distalizing. I go to 1.1 of a Catan.
I have experience with some of these failed MPFLs, and I'm concerned about the bony work that's already been done to the patella at this point. So I've in revision cases like this, and in some cases, primary cases, I'll do an MQTFL. I don't know if you guys have tried that before, but I really like that procedure. It's a little more resilient. Certainly no damage to the bone structure of the patella. And in a case where they've already had an MPFL that's failed, there's probably some damage to the bony structure from either anchors or tunnels that have been drilled. I'm not sure what the technique was used for the previous MPFL. I definitely agree with using allograft if there's a question of Ehlers-Danlos syndrome, and certainly an anterior medialization along with the MACI procedure to the patella.
I think the jumping J sign and the apprehension and deeper flexion pushed me to do a bony procedure, as did the MPFL failure. My question for Deryk and Dave would be, how does the trochlear dysplasia influence your ability, your thoughts about cartilage restoration, or does it, or is it more just influencing your overall treatment strategy?
That's a great question, Seth. I certainly would add the MQTFL or MPFL sometimes along with that, but I don't do any deepening of the trochlear groove. I haven't really had much success with that, and I'm concerned about that in a 13-year-old. Obviously, cartilage damage to that area. It is an isolated lesion on one surface. It's not a kissing lesion, so that certainly helps me as well. But you have to distalize, as Dave was saying. I think that's important. But I wouldn't address any deepening of the
Dave, I guess I agree with you. My question, Dave, I guess, is does it affect MACI versus OCA decision making? The
You know,
trochlea.
that's a great question, Seth. But obviously, for me in this specific case, I would lean towards more of a Macy. You know, if you're going to be dealing with something with the trochlea, which I have not had to do with both a trochleoplasty with a significant colors restorative procedure, you know, I could definitely understand your thought process with thinking of more of an OC allograft potentially in that situation. But honestly, you know, looking at the lateral X-rays for this is not something I would think would need to have any deepening. I think that this is truly get the patella engaged back in the trochlea at an earlier time point, and I think you're going to have success. We don't see a significant spur up there or drop off. So again, I think this can be successfully treated more from a distal osteotomy.
Okay, great
Excellent,
success
guys.
with
It's a great
13-year-olds and
discussion.
young people
I'm going to
with
move
their
on to see
cartilage
what
as well.
just,
Really
sorry,
heals
sorry,
well.
Deryk.
That's okay.
Just-
Yeah, just young people have great cartilage, so I use their cartilage. Their
Mhm.
cells are going to grow like gangbusters
Mhm.
for us. So
So just because of time, we're going to move on to the next slide. And Tom, can you tell us what you did?
Sure.
Oh, sorry.
Okay, so you can see the all the points you guys made were exactly the way I thought of it. You know, I wanted to distalize the tubercle. I wanted to get a good check rein medially. I will always go in a very systematic fashion. I always do a longitudinal incision that I can use for future reconstructions from the superior pole of the patella laterally to the bottom of the tubercle. I make flaps medial and lateral. I release the iliopatellar attachment of the IT band off the patella and do a lateral lengthening that way. And I'll always reconstruct it at the end. The next thing I do is a medial arthrotomy, identify my MPFL. Then I decide, putting the knee through flexion extension, where I'm going to distalize and center and unload the patella. You can see this is a medial facet across the midline ridge. And so I did a Macy for this. I also did a trochleoplasty. I found that no matter how, that's the last thing I do. So I do lateral lengthening, medial advancement, tubercle, anteromedialization, distalization. And if it still wants to slide off, which this one did, I'll do the technique of Peterson, the synovial advancement, remove the big bulb at the proximal portion of the trochlea and suture the synovium through the articular surface and on the margins. With 2-ovipral and through the articular surface with 6-ovipral. And that way it holds. And what you see over time is that develops a metaplasia. So that's what I did. Go ahead to the next slide, Ken. And you can see here, when I was finished, this was really, just by anteriorizing the tubercle a little bit, I found that the patella pulls down, and often and this one, I didn't really distalize the tubercle as much as I did the trochleoplasty, got it to center and to distalize just by anteriorizing it a bit. So, so this is what I did with her.
Oh, sorry. So I would just say for the listeners that this is not the formal de jour type trochleoplasty. This is something that Tom and I learned from Dr. Peterson, and it's a much less destructive and easier to perform. But it does get rid of the bump, really. It gets rid of that bump, which is the major issue.
Yeah, it keeps the joint congruent because, you know, if you have a dysplastic trochlea, the patella is also dysplastic because it's a sesamoid bone and is remodeled to fit that trochlea. But by doing a de jour trochleoplasty and deepening it, you make an incongruent joint. So that's the issue I have with those type of trochleoplasties. So for me, it's just getting rid of the bump and making sure the patella tracks centrally, and that's what we did.
Thanks, gentlemen. We're going to move on.
Tom, can I ask you one question? Distalization, didn't want to do that because of, for what reason?
Because when I did the tubercle and centered it, before I decided to distalize it, I found that the patella was engaging nicely through flexion from full extension. So the trochplasty, the MPFL, the lateral lengthening, and centering the tubercle, it was centering and it wasn't subluxing. So that's why I didn't distalize it.
And Tom, when you say MPFL, you just did a repair or a reefing?
Yes, correct. So what I do is I am not a big MPFL person. I've only done 2 in my entire career, and I do about 75 to 100 TTOs a year. And I find nearly always, I find a really good attachment to the adductor tubercle of the capsule and the soft tissues. So I will advance it. I'll just leave a little cuff on the patella, about a centimeter or less, and I will advance it and repair it. And I like Deryk's method of pulling down the quads tendon and leaving it attached to the patella if I needed to do any adjuvant reinforcement. But I don't go and harvest semi-T or anything like that. The only ones I've ever done allograft is Ehlers-Danlos.
Okay, we're going to move on to case 2, folks. Thank you, Tom. One thing I want to remind the participants, if you have questions, there is a Q&A function, and you're welcome to put questions in there. And if we have time, we will try to get to those as well. All right, this is another case from Tom, actually 34-year-old male, approximately BMI of 31 to 2. He's an avid rugby player, but also loves hiking. He's got moderate activity level now in his 30s. His symptoms are a constant dull ache, a 5/10 pain, swelling that gets worse with activity, even on cycling. And he'd like to get back to pain-free hiking and playing rugby. He's had no previous surgeries or any other comorbidities. These are his long leg films. As you'll see, he's got the weight-bearing surface through the affected leg is going through the medial tibial tubercle, so slight varus. Here's his standing X-rays and Rosenberg's. Here's his patella view, and you can see he's got a very slight, minimal patella baja on the lateral X-ray, looking at the CDI. The arthroscopic findings showed both a medial femoral condyle grade 3 lesion and a patella lesion at the time of harvest. Okay, Deryk, you want to start with this one?
Sure. What was the actual angle you measured, varus angle? Was it 3 degrees, 5 degrees? What did it look like?
It was closer to 5 degrees varus.
5 degrees varus. Okay. Yeah, I have a low threshold to go ahead and do a high tibial osteotomy in a patient like this. He's got a slightly higher BMI. He wants to go back to a really high level of activity. And so I think an osteotomy is certainly something we need to think about in this type of athlete. In addition, the cartilage lesions look like grade 3 lesions to me. It don't look like full thickness lesions. The adjacent surfaces were fine. No meniscus damage either.
No, his meniscus looked good. When you palpated with a nerve hook, you could feel the subchondral bone, though. It wasn't like
grade 4.
Gotcha. I think it was acting like a grade 4, even though it was cartilage left on the surface. So technically grade 3, though.
And where was the patella lesion on the patella? Was it medial?
It was central median ridge. Yeah.
Yeah. So I would do a high tibial osteotomy on this patient along with a Macy procedure if he was willing to take the time off to let it rehabilitate. I wouldn't let him go back to full activities such as rugby until approximately 9 to 12 months. One could consider an osteochondral allograft if he wants to go back at an earlier stage. That is something that I've used in patients that have a slightly higher BMIs and want to give back without taking the time off. Whether you stage or not, I would probably do a biopsy and then do all the procedures at once. So it would be my choice, probably a Macy along with a high tibial osteotomy concomitantly at the same time, waiting 9 to 12 months before return to rugby.
Very good. Other guys, any other comments?
Yeah, I can jump in, I guess. For me, if this patient's not having major mechanical symptoms, this is, non-surgical to start, just to hammer that home. I would use an unloader brace, maybe a knee sleeve. I'd use anti-inflammatories, biologic injections, try to get him to lose a little weight through nutrition and other pathways, just get him in the right mindset. And then have him test his knee once he's optimized. And then I think if he failed all that, then he'd go into the camp where Deryk was at. Briefly, asymmetric varus pushes me towards osteotomy, very low threshold, like Deryk said. I think you get the lay of the land at the time of the osteotomy, of where the cartilage defects are, and potentially come back at a later day to do cartilage, or you could take a universal approach and do all of that at once. I think either way is dealer's choice. And I probably would tend towards multifocal unipolar OCAs for a person this age and size, but I don't think that's right. I think that's just what I've done and seen.
Yeah, I would say similarly, for me, just with the varus and the continued issues with him, this is someone who's automatically getting an osteotomy. The only concern I would have is just both the locations of two of these lesions. So first and foremost, for me, in my hands, this is a multifocal lesion like that. I typically lean more towards a Macy graft, though I agree you can use Osteochondral Allograft as well. But the big thing is that patella lesion, and especially if it's getting a significant amount of loading, if that's where a good portion of that pain was, then we also potentially need to think about how to offload that. Whether or not you need to do two different types of osteotomies to offload the kneecap as well.
This brings up a good point. These bigger guys that have these BMIs that are borderline, and what kind of body mass index was he a very muscular guy, or was he just overweight?
No, he was not overweight. He was solid. Like, he's a rugby player that you don't want to hit
guys,
you.
Yeah. These are tough ones. Yeah. So that's what the osteotomy has got to be, a big plate. I use a big plate to fix these guys. And Seth brings up a good point. I mean, try some non-operative. I'm sure you did this already. Non-operative management to get the weight down a little bit if you can, but you're probably not going to lose much in these kind of muscular guys. So then you just got to go with what you got.
Yeah, we did that. We did unloader brace and steroids, and he hated the brace, and the steroids really didn't do much for his thing. And losing weight for him, he liked his food too much, and he was solid. So,
Now, let me tell you something.
These guys are tough.
If they're at their 40s, I'm trying to get them to lose weight. If they're at 31, where some of us live, that's not so bad.
Yeah, it's pretty. I'm being a little picky living in New Orleans, so I'd be happy with a BMI of 31 typically. So I'm not.
I thought what Dave said was a great point. Paying attention to patella height. I mean, this person started a little Baja. If you have to do a big HTO correction, you can make that worse. Some of the newer systems, we can use CTs and actually model and know what the patella height will be after your coronal correction. And you can do an easy anterization or proximalization of the tubercle. I mean, you're sitting right there. It is two different osteotomies, and I'm sure a different complication profile, but I've not seen that. And in rare cases, I've done both now, which I didn't do the first 5 years of osteotomies. Now, in my second 5 and beyond, I'm considering that in select cases. But this one, if it's central medial, I'd probably just do an HTO, and it wasn't a big correction. So I don't think you have to do it here.
I love the AO technique for that too. So that seems to be the one in this case with Baja consideration. Certainly something you'd want to use.
Okay, so we're going to move on now and see what was. For some reason, I'm not advancing. There we go. Okay. So Tom, go ahead. Why don't you discuss it since you did it?
Yeah. So I like this flip up technique of tubercle osteotomy. I think the guys all sort of hit the whole thing of making sure you don't drop them down further. So when you flip up the tubercle, you can put it right where you want at the end and make sure you don't increase his patella infra or Baja. So I go subvastus both on the medial and lateral side, so I don't touch the quads. I flip it up, and then you got this incredible exposure. You can do whatever you want. And so that's what we did for exposure. We radically debrided the defects, and I agree you can use either. I think in the patella, though, finding a good OCA match is very difficult. On the medial condyle is pretty easy. So when I have multiple defects, my preference is to use cells over allografts, but I still use allografts in certain indications. And then once this is all opened up, you can just do an opening wedge osteotomy and then put the tubercle down at the end. So this is a double planar osteotomy. And I would agree with Seth, don't start playing with these osteotomies until you got a lot of comfort with osteotomies, because things can go south very quickly. So we can go ahead and show the next slide, Ken. So this is very much old school, but I like this system. This is a first generation Poodoo plate. It's a stainless steel non-locking plate. I've been using it since about 2005. I find it is robust enough that I don't have screws break. It holds it nice. Very low profile. It's not something that's very easily palpable. And you can see the distal part of my tubercle osteotomy. I do an oblique cut, and I make sure that the plate bypasses that tubercle, so I don't have a stress riser. So that's what we did. And I think it. So he's doing all his hiking, and he's very happy. 1.5 years. I think with the allografts, I think you can be doing all the hard pivoting stuff by about 9 months to 12 months out. But I really think with the MACI or the cell treatments, it does take a little bit longer, and I kind of hold them off for 14 to 18 months before I let them go really hard.
Tom, you mentioned you get an MRI to assess the cartilage status prior to letting them back.
I do. Now, the problem is with all this hardware, you need metal suppression software to have a good look. And sometimes this is a stainless steel plate, it's not titanium, so that's an issue. If you don't have metal suppression hardware, you can have a hard time looking. So yeah, before I let them just go hard, I do a MRI scan at 1 year and 18 months. I want to see the tissue look like the native tissue on the repair. I want to make sure that there is no remaining bone marrow edema. And I want their clinical exam to have no effusion, no crepitus, and no pain. And then I just set them free.
So Tom, one of the questions from the audience was about that exactly. Are you concerned with a MACI that 9 to 12 months, reloading it for rugby is a little bit too soon?
I
And
agree.
I
I
think
think
what
it's
you're saying
too
is that's
soon.
absolutely true, and that you do an MRI to help you decide that. If it doesn't look ready at 12 months, it isn't ISO tense, you look and wait till 18 months.
Right. So if it still has fluid signal uptake at 9 to 12 months, which often it does, it's still a soft graft. So I wait it out.
I would just add for both. I mean, there's no free lunch. With MACI, you have to wait for it to grow and remodel. And with OCAs, we have to wait for bony creeping substitution. And, that's a biologic process that has a set time frame. And while our athletes want to get back faster, it sometimes is a game of patience so that we don't have
Right.
catastrophic harm.
And remember with allografts, with creeping substitution, as Seth said, if you get failures, they're early. They're in the first 2 years. So when you look at these 10-year survivorship of allografts and you say there's 75% survivorship at 10 years, that means a quarter of them have failed. But nearly all of those that fail are in the first 1 to 2 years. If you get past 2 years, they go forever. They do really well.
One last question from the first case, but this could be answered here as well for the panelists. I know you're feeling, Tom. So for the panelists, just somebody wrote, does the panel believe in any osteochondral transplants for the patella or always uses MACI on the patella?
I'll start. In a 13-year-old child, as I said before, I would always use their cells. In my experience, I think they grow really well. I've had some really early returns of great function with young, adolescent 13-year-old to 17-year-old kids. If they're older, this type of guy, I'm thinking their cells are less active than some younger person's cells. Then I'm definitely thinking about osteochondral allograft from the patella, and I do that quite frequently.
And lastly, before we move on, here's a beautiful picture, a 2-year follow-up that Tom did arthroscopically, and you can see the patella on the right and the medial femoral on the left.
So we did this. He wanted his hardware out because it was bugging him. So every time I pull a hardware out, we always talk about, let's go look at your tissues. So I always scope them. So this was a nice chance to look at it. And you see there's a little bit overlapping hypertrophy in that medial femoral allograft, even with a MACI. So I just trimmed that down. But the patella, you couldn't even see where it was, except for that it was whiter than the native tissue. So I do like MACI on the patella. For me, it's number one thing. I do some allografts. On the medial condyle, I agree with the others. You can go either way, MACI or allograft on a weight-bearing condyle.
Very good. Before we move on, we have one comment. Alex Meininger does say that he's been using in the patella the fenestrated OCA allografts with some suture anchors. And there are a number of new products from various bone bank areas that might be considered for that as well. Okay, Tom, let's go on with the next case. You present it, number 3.
Okay, so this is, I had a lot of these patients in Boston. These were, patients who were on medications for their ulcerative colitis or asthma or after lymphomas, high-dose steroids. This 32-year-old woman, she BMI is 24. She's a painter, an artistic painter. But she's still fairly active as far as walking, hiking, cycling, no impact loading activities. She had avascular necrosis of both her shoulders and both her knees that was discovered in 2007. She'd been living with it for quite a long time. I met her when I moved down to Florida in 2018. And she'd only been offered total knee replacements by all the other surgeons she saw, and she didn't want to do that at such a young age of 32. So her goal was just to be comfortable with activities of daily living. So here you can see her mechanical axis is just slight varus to the medial tibial spine, about 2 degrees of varus. And you can see both knees appear to be involved. Medial femoral condyle is resorbed and collapsed with what appears to be avascular necrosis. And her standing AP and PA views, however, still show there's a patent joint space. So her joint space hasn't collapsed. So go ahead, Ken. And you can see here that it looks like she has her joint space and her patellofemoral joint also is intact. And it looks like she has some extensive involvement in both tibia and femur with infarctions. So here you can see on her left knee, she's got some infarcts in both epiphyses of the femoral condyles and the metaphysis. And on her medial compartment, it looks like it communicates with the surface on the femur, but not on the tibia. And I think, is there any more, Ken? Any more MRI images?
That's it.
No, there aren't. Okay, so that's it. So that's basically where we stand on her.
All right, we're going to start with Seth Furman. This is a little different case than our last two.
Yeah, so I think these are patients we all see, and I think challenging problem. Sometimes they've recovered from challenging illnesses, systemic illnesses, and so now we're talking about their knee. And while it is major dysfunction, it's we're at least moved on from big things and have control and go musculoskeletal. I don't know. I think her activity demands are very reasonable. She wants daily life, results. So I think, again, different than some of our active athletes. So where to go from here? I think she needs clearly surgery. I like scoping to see what goes to the surface. I don't tend to treat things that are below the surface that I can't see with the scope. That medial femoral condyle is clearly relevant. The others may or may not be. She's symmetric varus, and it's only 2 degrees, and and a systemic process. So I'm on the fence here with osteotomy, although it's not wrong with such a big defect. It's never wrong to put it through the spines, but I'm not sure I'd go there. And then it's really bone and cartilage treatment for sure. So it's either sandwich Macy or larger osteochondral allograft. I think I would think long and hard about maybe doing a medial femoral condyle osteochondral allograft and considering not doing osteotomy in this case. But you could also do sandwich Macy with a small correction, and that would be correct as well, in my opinion.
Deryk and Dave?
Yeah, I mean, obviously this is a difficult case, and I agree with someone who's young. You always want to think of how can we preserve this joint for a little bit longer. She's obviously going to be heading down at some point in her life towards that replacement. But if we can, again, buy some time, that's going to be the most important. So for bone and cartilage problem, especially with such widespread like this is where I typically would lean more towards an osteochondral allograft. Someone who I would temper with this, especially for her case, she still has an active, I would say, chronic inflammatory state with the ulcerative colitis. And if I remember right, Tom, you said she's on chronic prednisone still for that. Is that correct?
She had been on high-dose prednisone, but now she's on one of those TNF alpha blockers, and she's off steroids. So she's, I think steroids knocked her into trouble, but the TNF alpha blockers now, she's stable without steroids.
Oh, perfect. So, I mean, again, I would approach this very similar to what Seth had said, but I would lean more towards a structural osteochondral allograft. I'd be a little concerned as well about the tibial osteotomy on this one. Again, you're not wrong if doing so, but I think I would try to just address the cartilage issue with the osteochondral allograft.
I would probably do an osteotomy for sure. I think the tibial surface shows a little bit of wear. I'm seeing a little thinning of that cartilage on the medial side of that tibia. It looks like the lateral compartment, it has good cartilage. It has a little bit of AVM, but it looks like it's stable. So I would do a limited osteotomy, and I would definitely do some form of autologous bone grafting. I don't know whether you want to do an osteochondral allograft over the top of that to limit your bone load. I have gotten burned by trying to put too much bone in with an osteochondral allograft and not getting that creeping substitution required with bulk allografts. So you got to limit that bone load in this situation. She's not going to heal that in really well. She's already demonstrating that she has a bone problem. So autologous bone grafting, I would pack the heck out of that medial femoral condyle. And in most cases, I probably would still do a Macy sandwich technique. I've had great success with that.
Okay, gentlemen, let's see what Tom did. Unless any other comments, any other questions before I move on? We're going to move ahead. Okay, Tom?
So I treated a lot of this stuff when I was at the Brigham. We had Dana-Farber Cancer Institute and Beth Israel Hospital, which had the inflammatory bowel disease asthma unit and then the cancer unit. And I would probably get one of these patients every 2 weeks sent to me. And so Seth's point about arthroscopically assessing them to see where the articulations are soft is a very good one. And at the beginning, I used to do that all the time. I would always scope them before I made up my decision. And I would look for the infarcts that are right against the bone. They're the ones I would treat. The metaphyseal ones may cause pain, but they don't collapse. So I looked for, defects that would be there. And after a while, I started really correlating, the MR with the arthroscopies, and then I stopped doing scopes. And eventually what I would just do is just go ahead and just open up the knee and have enough tissue available that I could just assess what is soft based on the MR. So MR is really important. You need your MR and you need to know where to look to see what's soft and what's damaged. And if I saw it was all soft and fissuring and the cartilage was delaminating or just coming off, I would use an allograft. And so you can see here, I used a whole distal femur because I was concerned about damage to the trochlea, the medial condyle, and even the lateral condyle. There was some evidence that the infarct came very close to that surface. So I agree with Deryk's and David's concerns about doing an osteotomy to unload that site if you're going to do a cell-based therapy. But for me, unless I know it's just a single large infarct with steroid-induced infarcts, I may do a sandwich there, but I would usually use my sandwiches for idiopathic AVN without a steroid-induced cause because I found these were more extensive. So you can see here, I did 1, 2, 3, 4 grafts, and I think I even did the patella. And I have a low threshold for using fixation if they're really large areas of damage. Because you get better fixation when it's a deep defect, but then it means longer creeping substitution. So I don't like to make really deep plugs. And if I need really good stability, I'll fixate them with headless screws. So here's what we did.
Sorry, there we go.
Yeah, and you can see here, that's what I did. I used headless screws on all 4 defects. So what's amazing with this is just how rapidly they recover and their pain goes away. By 3 months, she was pretty much pain-free on this knee. And by 6 months, we went ahead and did her other knee. And so she's now about 3 years out and continues to do very well with this joint salvage situation.
Let me see, before we move on, there's a couple of questions here. Can you please comment on the utilization of de novo versus Macy? And I guess that's from the last one. We'll come back to that at the end of the session. I'm sorry, I thought it was related to this case.
Tom, do you have challenges with getting approval for these 1-stage cartilage repairs, OCAs without a scope, or?
No, I don't actually. It's pretty straightforward. We just document the infarction locations and where they're located. And, then we just put through for our approvals and they get approved. So I haven't had to do a scope first. I usually am able to go straight to, especially on if there's one graft that looks like, or one site that looks like it's resorbed and collapsed clearly. And if your MRI report states that, then usually it's a non-issue. You submit the MRI report from the radiologist in addition to your interpretation, and it goes through pretty straightforward.
Dave and Deryk, do you think you guys would have ordered a medial femoral condyle on this or a full distal femur? Because
I was going medially myself, but I love that. That's progressive, you know. I like it. Do you drill the base of all the lesions? Did I notice some blood flow drilling the base of the lesions to get blood flowing?
I do. So I'll go down until I think I get most of it, and then I will drill down until I have bleeding bone, and then I'll come back. So I don't try to get rid of all the necrotic bone, but I do want to see that I'm down and I do have good bleeding bone before I'll decide on the depth of my allograft.
Hey, Seth, to answer your question, you know, I've erred more and more on large defects or lesions like this, to where I will ask for a full distal femur. I think you just, you know, too many times we get surprised, right? And right now we're trying to restore the geometry of the joint and also restore all these defects. So it just allows that ability to really kind of pick your grafts from the best locations. And again, if you have multiple sites like this, you can accommodate. So especially if I see a large broad one like this person had on that medial femoral condyle, I would err towards a full distal femur.
So let's just talk about the cost of these things. A distal femur, this costs $20,000. A heavy femur is about 12 and a half, and a single condyle is $7,500. So, you know, your hospital does raise their eyebrows when you order a whole distal femur. So just be aware of that as well.
Dave, do you use bioheadless when you need fixation or metallic?
I typically use bioheadless, or just even if it's a shallow one, I'll just use more of the, I would say like smart nail type of aspects, right? I don't like the bioabsorbable screws. I've definitely have had issues with that as a tertiary center of significant failures from outside institutions from that. So if I'm going to use any type of metal or screw, then I'm going to use metal. Otherwise, I'll use a tack.
Tom, I have one more question. And this was asked also by somebody in the audience. I was thinking, saying, do you pack bone first so you can keep a smaller OCA allograft, or do you make a thicker OCA allograft? Do you try to keep minimal bone from the allograft by packing autologous bone first, or what on these deep defects?
Right. So as I mentioned before, I'll ream and I'll look, and I'll ream and I'll look. So I try to make sure I get, say I ream down 5-10 millimeters and I see half of it still looks sclerotic and dead and the other half looks really good, I'll probably accept a 10 millimeter thick graft, and I'll drill through all the sclerotic bone and until I see that it's bleeding. Because around the margins usually I'll find that it's healthy all the way around, and it's really at the base where it may still be infarcted. Because you see some of them have these deep metaphyseal infarcts. So, I mean, you can't get rid of all that stuff. But I think even just drilling all the way through it and getting blood through it, you decompress the intraosseous pressure, which helps with some of the pain, I think. But it also probably helps it to heal better. So you may not have 100% healing, and you may never get 100% of it undergoing creeping substitution, but it certainly makes the surgery a lot easier, and it still seems to be quite effective. And I've been doing this for at least 10 years, and surprisingly, they do well, and I can't recall a failure of them resorbing and collapsing. They're pretty low demand patients.
Yep.
Two quick questions. Guys, one question to Tom. Just do you remove those screws?
I don't. No, I don't do it as a routine. I sink them down a good 5 millimeters. I want to make sure they're well into the bone, and that you can't even, they're far away from the cartilage in case it wears down, that the bone is protecting the screw head so it doesn't scrape the tibia.
And BMAC for the OCA, is anyone doing or not doing? Yes or no?
I don't.
I've actually been doing some umbilical injections in cases like this that I found is helpful. A particular type that I found is helpful, but I haven't done. I've done a little BMAC in the past, but I don't use it typically.
Jury's still out on it.
Jury's out, but it's not a bad thing in an area where the bone is clearly dying and not doing well. So it's a good thought. Okay, we're going to move on to our final case. This is a case from my institution. Actually, the primary physician originally was Dr. Mike Sakili. I'd like to thank him for sharing this patient with us. This is a 31-year-old female, BMI approximately 24. She's a former marathon runner. Now her activity level is quite moderate. She's got 6 to 10 pain with 6 to 10 pain localized to the lateral aspect of the knee, worse with stairs and squatting. She did have a patella episode of patella dislocation in 2004 that began this during a soccer game. No complete dislocation since then, but multiple subluxations weekly. Her goal is pain-free ADLs. She's already failed PT, obviously, patella stabilization, taping, bracing, steroids, and HA injections by other surgeons for over 5 years, but there's been no previous surgical interventions. I would say the notable physical exam signs were a positive J sign, positive patella crepitance, and an out-towing that's notable with an increased prone thigh foot angle. Here's the regular weight-bearing X-rays and the noticing just slightly elevated or just the high end of normal Caton de Champs. The patella view, you can see it centers at that in that position, maybe a little bit of trochlear dysplasia, a little bit of a crossing sign, maybe de jure. So overall, and here's the long leg films which show a valgus, slight valgus. So it goes to the weight-bearing line comes through the lateral tubercle. So mild to moderate trochlear dysplasia, possible crossing sign. There's some anteversion in the femur, notable on the hip X-rays. Joint spaces are preserved. As we said, mild valgus. The MR is on the right, shows grade 3 to 4 chondral lesion of distal patella. And there's, as we said, mild trochlear dysplasia. TTTG is listed there. There's no gross ligamentous or meniscal abnormality. The MPFL is intact, but just attenuated. Okay, here's this arthroscopic view when in for harvesting our options, and that shows the patella lesion. Otherwise, the rest of the knee is in pretty good shape. So who would like to take this first? Everybody started with one. This is a little different case, also patellofemoral case.
Yeah, I'll start. So again, I think a great case, again, something we commonly will see. So we have a patient here who's had both pain and instability. So failed other conservative measures, obviously had their scope. So we're past that point. And so in this type of thing, I'm again looking to address both of those issues. For the instability in looking at her assessment there. Obviously, she is in a little bit of valgus, but I don't see any defect on the lateral femoral condo, so I would not address that valgus with anything in the femur. I would address more that TTTG to help with the cartilage, and then the second thing I would do is really address the instability with an MPFL reconstruction, and likely with the J sign, a lateral lengthening as well. So that's kind of my thought process through that with the two issues that she has.
Any other workup anybody would like to see before making their final decision after the scope?
I think I have enough information. I'd like to tease out more. A lot of these patients started with instability episode or episodes, have a quiescent period, and then come back with painful patellofemoral chondrosis. And it seems to me like that's where she is. So I'd need to know from my exam if she's still unstable or not with apprehension, because I may leave that medial side or leave the instability aspect alone. This is about cartilage mapping to me. This is distal and or distal lateral with lateralized force vectors and alta in a former runner. To me, that's an isolated unloading TTO and call it a day. So maybe some soft tissue balancing laterally, but that's it. I'm not going to get aggressive for cartilage in this patient.
So the as you mentioned, that history is what happened. It started with instability, and of course it migrated to this situation, but she hasn't had any major dislocation episodes where she had to go to an ER, but she does sublux and is quite apprehensive. Yeah,
then I think the only thing I'd add there would be after I anterize, slight distalize and medialize, so I put the tubercle centered and offload the chondrosis to good areas. I would add the soft tissue balancing, either the way Tom does, restore the resting length of the native tissue, or allograft recon. I think it's a dealer's choice once you've done the bone work.
Deryk, any other questions?
Grade 4 lesion of the patella, correct? Was that?
Yes.
It was distal and distal lateral. Yeah.
Distal lateral. Yeah. Yeah, I would absolutely do a Macy procedure concomitant with a tibial tubercle osteotomy, anteromedialization and distalization procedure in this patient.
Okay, so
So Deryk and Seth, let me ask you, because the CD index was only 1.2. Why would you distalize this one?
Yeah, I think the location of the
Conversation.
lesion,
Yeah.
and it's a borderline. So my thresholds for osteotomy, particularly including anterization for medialization or anterization for distalization, are lower for cartilage. So, Catan Deshana 1.4 for pure instability, and TTTG that's very high, with other factors for pure instability, it's lower. TTTG 15 and Catan, pretty much that's anything that can offload the cartilage to better proximal cartilage. I'm on board for. So
Yeah,
I guess
absolutely, same exact reason. I want to unload that cartilage distally with the osteotomy.
Ken, could I ask just an additional question? The
Certainly.
when the arthroscopy was being done,
Mhm.
any sense on what the lateral tibial plateau felt like arthroscopically? I've found in a lot of these valgus knees that it's not the femoral condyle that goes in valgus, but what you start seeing first is softening and fissuring of the lateral plateau. And that
Well,
guides me as to whether I
it's a
can
good
take it out
point.
of
There was,
valgus.
yeah, there was no obvious fissures or big cartilage lesions, but it was, underneath that meniscus, a little soft.
And you
Sort of
commented
grade
on the
1.
rotation of the leg as well. Were both legs affected, or just this leg that was bothering her?
This is the only leg that was bothering her because of that dislocation episode, but she did have rotation in both legs.
Equal or unequal?
No, this one was a bit more. You'll see in a moment. So speaking to that, we felt that this, we've had a lot of discussion at Lennox now, especially now that we have these newer systems that allow us to do a little more precise osteotomy, like Seth was discussing, that this might have been sort of a miserable malalignment. She has valgus, a little bit of femoral anteversion. She has instability. She has the high TTTG. We might not be able to address everything, and we wanted to see where the major issue was. So we did this full-length CAT scan, and the full-length CAT scan then can be analyzed, and you can see not only on the CAT scan is the TTTG a little higher, but there's a little bit of femoral anteversion, but a lot of external tibial torsion. The normal would be up to 20, 25, and this is, the average is a little less than that, and this is 45 degrees. So the decision was made to utilize preoperative planning and to try to address the valgus just a little bit, but mostly address the rotation in this case. Now, there's nothing wrong with attempting to do a balance, soft tissue balancing and a TTTG, but we felt the rotational component here was much bigger. And we've been discussing that, and we've had about 3 or 4 cases now with my younger partners that we've done these rotational osteotomies with some good success. So the plan was to bring the rotation down to 20, which of course would address your TTGE's issue as well, and to just place a slight 1 or 2 degrees less of valgus into the osteotomy. And that's what we did. As you could, this is just showing there was a J sign elicitable like on Tom's video. Unfortunately, this video isn't running. Here's the lesion. It was actually a little more central and bigger, as always, when you get in there and take a look at it. So we dealt with the lesion, but here you can see this special cutting guide that comes with this particular proprietary system. And both the cutting guides as well as the plate and screws are all custom for this case. So you know where you want to end up, which really decreases the number of intraoperative X-rays you have to take and the total time for the case. So the patient had the the cartilage dealt with and the derotational osteotomy. And here is our post-op X-rays showing that the alignment looks pretty good. And I think we should, no, sorry, I thought we had a Patella X-ray. I forgot to include it, which looked very nice as well. Anybody want to make some comments on that? Obviously, this is a little different way to handle this, but, and it just talks about, for the audience, how there's multiple reasons for patella instability and malalignment, and while they often can be addressed with tubercle and this, that sometimes considering rotation may be a major issue. And this patient at 6 weeks has no J sign and is pain-free, minimal pain. Range of motion at the moment is only 0 to 110, but expect that to increase with time.
And I would just add for the record that with that size and location of cartilage defect, I would most certainly treat it like the others would.
Yeah,
so
it looked worse open than it did.
Yeah, it's not an offloadable lesion with just TTO. And I guess the last point, TTTG elevation comes from anywhere, right? It's a final summation. So it doesn't just mean tubercles lateral. It can mean version, it can mean torsion, it can mean medialization of the trochlear groove center, or combinations thereof. So in this case, you picked the biggest deformity, and I think that's very reasonable. I don't think you would have done this 4 years ago without a tool to help you get there, because this is fearful without
Well,
guidance.
let me say that I have no real long-term history of rotational osteotomies, although other people do, but I certainly didn't. And these new, there are two companies, that make these CT-driven systems, and boy, does it make it easier, especially when you're trying to address multiple planes.
It's awesome. Great
Yeah, I'd
case.
like to comment on a couple things, because I think this is a great case. I have not personally done a rotational osteotomy, so I'm not going to talk from experience here, but I've dealt with poorly performed rotational osteotomies and having to take them down. And first of all, it's a nice long midline incision, which I like. It allows you to deal with the patella, the medial tibia for your osteotomy, and to release your lateral tib-fib joint in order to rotate it. It's a two-bone system. You can't rotate it without doing something to the fibula. So that allowed you to do everything. And what's also cool about this is they did a small closing wedge tibial varus osteotomy to get it neutral, which it's very, to do that on the tibia, you have to have a normal distal femoral angle. And this one is relatively normal, right? It's not a superolateral slope and a hypoplastic lateral femoral condyle like you normally see with a valgus knee. So that's the other reason you could get away with this. But I think this is really elegant and very well thought out. And the last thing I noticed is, if one leg is more rotated externally than the other, that you should immediately think of doing something like this, because you correct that rotational deformity as well. But if they're both rotated, say 45 degrees, I would have a hard time, if the other side is asymptomatic, doing this. I would probably leave it in the alignment it is, and just do what Seth said, just do a tubercle osteotomy, do soft tissue balancing and a Macy on the patella. So if they're both really externally rotated, the other side's asymptomatic, I probably would not have done this. But in this situation, I think it really did this patient a service.
Concerned about gait disturbance postoperatively if you do asymmetric or symmetric.
Well, this case, yeah, that's what he's concerned about. But in this case, it's too soon to say. But I will say we have a patient who had bilateral recurrent instability. All other things failed. And another one of my partners, it was the first one I scrubbed in and to see this technology when we brought it in. And this patient had a derotation with her other leg several years before. And did well, but it was a very long recovery and it was a very long case, several hours. This case done with this CT guided stuff and this very well-placed plate, this patient was sort of pain-free in a few weeks and was very pleased to have a second one done. And the big difference was the case took 55 minutes with one intraoperative photo compared to the one that was done with the old technology. So, but yeah, there would be a potential gait disturbance if you have bilateral and you don't address it. That's
Was the opposite side femoral based? Ken, was that femoral based osteotomy?
Say it again.
Was that the opposite side done in a femoral?
No, the opposite side was just done without CAT scan guidance,
without CAT scan,
with a rotational tibial osteotomy, but it was just a much more difficult case.
Gotcha.
So anyway, folks, this is coming to the end of our webinar. We're at 1 hour. It has really been great. I want to thank the panelists. I'm quite impressed. They basically hit on every case, all the thought processes that everybody had. And that shows you what experts they are. Tom, thank you for presenting so many of your great cases. Tom, would you like to take us out by thanking our hosts and sponsors, and then we'll put this up the next webinar.
Well, you guys did an awesome job. Thank you. These are cases that I see in my practice every day, and they make me scratch my head. And so I'm glad that that you also found them enjoyable. But this was really a great webinar, and this would not be possible without our sponsor Vericel. This made it a webinar that is educational and for free for all of our participants, of which we had over 300 signed up for today in over 58 countries around the world, including Tibet. So welcome everybody virtually. And thank you all for being present, and especially our illustrious experts. And Ken, always a pleasure to work with you. This was fun putting this together, and I hope everybody had fun with it, because that was our intent: education and enjoyment. So,
And I want to thank Anouk
everybody.
and Stefan and the staff at ICRS for helping us put this together.
Absolutely.
Thanks, Tom. Have a great day, gentlemen and ladies, and all the folks that joined us from around the world.
Thanks, everybody.
Take care, everybody.
Bye-bye. Thanks.
Thanks.